That's all I had tried. No worries. You couldn't hear me, right? All right, let's see. Can we? Okay, thank you. I'm getting the hands up. Thanks. For all, let's please find our seats so we may begin. 10 o'clock. Good morning and welcome, everyone. My name is Dr. Attila Uner, and I'm the Chair of the Commission on Emergency Medical Services. I would like to welcome you to the Commission on EMS meeting of September 21st, 2022, and I will call the meeting to order now at 10 a.m. To begin, let us all rise for the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thank you. We are returning to an in-person format. This meeting is being conducted in a hybrid format. Members of the public may attend the event here in person or may view a live stream of the meeting through the YouTube link included in the agenda packet. To efficiently manage the meeting's public testimony, EMSA has provided the public with the opportunity to directly address the Commission before or during the meeting pursuant to Government Code Section 11125.7. The Commission will consider all submissions of comments or questions on specific agenda items or topics within the Commission's subject matter jurisdictions. If any audience members here today would like to make a public comment or pose a question during the meeting, please do so by raising your hand to be called upon to speak when agenda items are open for public comment. If you are viewing the live stream of today's meeting and would like to submit public comment, please email your comments to webmeeting@emsa.ca.gov during the meeting, and they will be read out loud on your behalf. I'll repeat that, webmeeting@emsa.ca.gov. Please understand that there is a 2-minute limit for public comment. The complete agenda packet and meeting materials are available online at emsa.ca.gov/EMS_commission_meetings. I'll repeat that, emsa.ca.gov/EMS_commission_meetings. Our first order of business is to call the roll and see if we have a quorum. Commissioner Barrow. Commissioner Barrow is not present. Commissioner Brown.
Present.
Commissioner Burrows.
Here.
Commissioner Dunford.
Here.
Commissioner Gautreaux.
Here.
Commissioner Giandomenico.
Here.
Commissioner Gordon. I believe Commissioner Gordon is excused. Commissioner Kuzman.
Here.
Commissioner Lamb. Don't see Commissioner Lamb. Commissioner Miller.
Here.
Commissioner Oshita.
Here.
Commissioner Reluccio.
Here.
Commissioner Rodriguez. Commissioner Pierce.
Present.
Commissioner Snyder.
Present.
Commissioner Suver.
Present.
Commissioner Thompson.
Present.
Commissioner Valeri. And Commissioner Uner is present, so we have 1, 2, 3, 4 absent. I still think we have a quorum. We have a quorum, and so we're duly constituted to conduct business. We'll proceed with agenda item number 2, which is review and approval of June 15, 2022 meeting minutes. That's our first order of business. Is there any commissioner discussion on the minutes? Any members of the public, any public comment on the meeting minutes from last time? Seeing none, is there a motion to approve the minutes?
So moved.
Snyder, second.
So we have a motion to approve the minutes and a second. We need to do a roll call on this. Commissioner Brown.
Abstain.
Commissioner Brown abstains. Commissioner Burrows.
Aye.
Commissioner Dunford.
Aye.
Commissioner Gautreau.
Abstain.
Commissioner Giandomenico.
Aye.
Commissioner Kuzman.
Aye.
Commissioner Miller.
Aye.
Commissioner Oshita.
Aye.
Commissioner Reluccio.
Aye.
Commissioner Pierce.
Aye.
Commissioner Snyder.
Aye.
Commissioner Suver.
Aye.
Commissioner Thompson.
Aye.
And Uner votes aye. That's 12 ayes, 2 abstains, no nays. And if any commissioners join the group and I don't see them, please tell me. Agenda item number 3 is the director's report. Director Elizabeth Basnet.
Hi, good morning. Can folks hear me okay? Is my mic on? Okay. I just want to say thank you all again for being here in person. The conversations are so rich and lively when we can do this in person instead of virtually, and have really appreciated that all week. I will refer my director's report this commission to the agenda because there are so many things that we are covering that I would normally cover within my director's report. Thanks.
Thank you for that brief report. The report is published. Is there any discussion among commissioners? Seeing none, any members of the public? Good, and this is not a voting item, so we can move on to agenda item number 4, the consent calendar. Copies of the administrative and personnel report, the legal report, and the enforcement report are available online in the agenda packet at emsa.ca.gov/EMS_commission_meetings. I will now open up the consent calendar for commissioner discussion. Any discussion among commissioners? Any members of the public? Seeing none, we need to get a motion to approve the consent calendar.
So moved.
So moved. Thank you, Commissioner Dunford. Any second? Thank you, Commissioner Burris. We have a motion to approve the consent calendar. We will again do a vote call. Commissioner Brown.
Aye.
Commissioner Burrows.
Aye.
Commissioner Dunford.
Aye.
Commissioner Giandomenico.
Aye.
Commissioner Kuzman.
Aye.
Commissioner Miller.
Aye.
Commissioner Oshita.
Aye.
Commissioner Reluccio.
Aye.
Commissioner Pierce.
Aye.
Commissioner Snyder.
Aye.
Commissioner Suver.
Aye.
Commissioner Thompson.
Aye.
Commissioner Uner votes yes, so that's 13 ayes, no abstains, no nays. Motion passes. We move to agenda item number 5, EMS administration, presented by EMS Regulation Manager Kent Gray.
Good morning. Pardon me for being tall. Thank you. The legislative report for this quarter. The legislature has adjourned on the 31st of August, so all bills at this point in time were either passed and sent to the governor, or because this is the second year of the 2-year session, they are no longer in existence and will need to be reintroduced in the session beginning in December later this year. We were tracking specifically 3 bills that were passed out of the legislature that have been sent to the governor's office. One of those bills, AB 2130, has been signed by the governor and is chaptered. I believe it was on September the 6th. AB 2130 will require that all EMS personnel from EMT 1 up to paramedics receive, as part of their initial training, a minimum of 20 minutes training on human trafficking. This becomes effective on July 1st of 2024 to allow time for IMSA to promulgate regulations to alter our standards for education, have requirements that kind of are prohibitive, so we'll make the necessary changes to recognize the 20 minutes. And also, the training programs will need appropriate time to get personnel in place and programs and curriculum to meet this requirement as well. So while the law will be effective July 1st, the requirement will commence, the law will be effective January 1st. The requirement will commence for all new licensees beginning July 1st of 2024. The other two pieces of legislation are still in the governor's office and have not been acted upon at this particular point in time. AB 2260 is a trauma kit bill that would require trauma kits. It defines what they are and what should be in them, and specifies that they are placed in specific buildings in specific numbers depending on the type of building. These buildings would be those that are constructed after January 1st of 2023, and it also allows that the local medical director for the local EMS agency may add items to the list. And finally, AB 2117. This bill proposes to create a definition for a mobile stroke unit. There are two of these currently operating, I believe, in Los Angeles and San Mateo. And they would define specifically what they are as multi-jurisdictional, with oversight from a physician, either in person or through a teleconferencing system. And these items remain on the governor's desk. The governor has until September the 30th to veto them. Inaction does not create a pocket veto like it does at the federal level. They would actually become law should the governor not act one way or another. And that will conclude the legislative report from my end. If there's any questions or comments.
Thank you, Kent. I was remiss in not mentioning that the EMS Authority's legislative report is available online at emsa.ga.gov/legislative_activity. Any discussion among commissioners? Commissioner Gocho.
I have a question about the mobile stroke units. Does the legislation provide for the LEMSA medical director to approve the medical director for the stroke unit, or is that something for regulation following?
It actually, I believe, is currently, it has to be approved by the LEMSA. I don't think it, as the definition goes, I don't think it goes to a specific individual as the legislation is proposed.
Thank you. Further questions from commissioners? Any members of the public? Seeing none, thank you, Mr. Gray. We can go on to regulations update.
And I'm back. In this case, I didn't quite memorize. I have to put my eyes on. There are only a few updates. For the most part, things remain in process. We're working on we've returned to work on the child care providers, the Chapter 1.1. The EpiPen Chapter 1.9 is also being worked on. I am actually excited to report that the paramedic fees regulation was submitted to OAL and received their approval for notice. They will be officially noticed on Friday, and that will begin the 45-day comment period, which will conclude, I believe, November the 7th. So those will be forthcoming in just a couple of days. We are continuing our work on administrative medications to add the 4 medications in question to the regulations for state use. I'm going to leave the community paramedicine and alternate destination to Acting Director Bassnett and Mr. Meyer over here in just a moment. The work groups continue to meet for the trauma care systems, and work continues on the various areas in the systems for data collections, dispatch, and plans.
Thank you, Mr. Gray. Any comments from commissioners?
I have a question.
Please.
I just wondered if there's any update. Yeah, is it working? Is that working?
It's a very
Okay.
direct microphone.
All right, all right. I usually don't have a hard time hearing my high-pitched voice. But AB 450, is there any updates, the disciplinary board bill on regulations, or do we know what's happening with that?
Yeah, well, the paramedic fees are in response to AB 450 from our end. The board itself will be who's required to promulgate any regulations from that point, and I'll defer after that.
Yeah, Commissioner. So on that, we have drafted an internal AB 450 implementation plan. We worked through legal on some of just the questions and how the process will work. I believe, I would need to verify, I believe we've had 3 members that have been appointed, maybe 4, and we're waiting for the governor's office as well to appoint the final 3 members. Once those 7 come on board, we'll review that implementation plan with them, and then just start to walk through all the steps that are outlined within the statute to promulgate all the things that we've discussed. So it's on our radar, and we're waiting for those appointments.
Thank you.
Thank you. Any further discussion among commissioners? Welcome, Commissioner Lamb. Seeing none, any members of the public want to ask questions about the regulations update?
Do you want me to give a quick community paramedicine update, Dr. Inner?
Sure.
So for the community paramedicine regulations, triage to alternate destination, obviously, as we updated last time, we submitted those to the Office of Administrative Law. As we work through that 30-day process with them, there are some technical changes that are requiring a 15-day modification period, public notice period. Our goal is to get those out for modification next week. Many of those, as we said, are for technical changes. Then we would ask the commission to come back together again to vote on the new package, and then resubmit those to the Office of Administrative Law before our 1-year rulemaking time is expired. So I think in terms of timing, we would expect if we notice next week and we have 15 days and we reconcile those comments, put the new package together, we would ask the commission to meet sometime next month, mid-next month, to vote on that package again in a non-regular session.
Thank you. This will be an online meeting, I assume. This will be an online meeting, I assume.
Yeah. Yes.
Thank you. Any further discussion among commissioners? Commissioner Burrows.
Just a question on the technical requirements. It doesn't change the scope or substance of any of the regulations at all. It's simply legal technical changes.
That's correct. And then the other thing, just because it's sub-bulleted under here, I just want to update on the toolkits. As many folks may or may not know, IMSA is working in collaboration with CareStar Foundation and many other organizations to develop a triage to alternate destination toolkit, as well as community paramedic toolkit. We have separated these out. Most partners would not implement both at the same time anyway, and it can get very funky when trying to read one toolkit that has 2 programs within it. So we're working on developing those toolkits and hosting workshops in December. Obviously, that timeline got pushed a little bit as well with the 15-day modification that we have to have, but really excited to potentially deduplicate some of the effort for folks that may want to stand these programs up statewide. So just an exciting initiative and tool that folks may want to use. So wanted to announce that as well.
Thank you, Director Bassnett. Any discussion among commissioners? Commissioner Kuzman.
Thanks. So just a quick question. My understanding is that this 1544 set a sunset date in January of 2024. So assuming the regulations come, back to this group, we're probably looking towards year end of this year, I would imagine, which gives essentially a, 1-year window to be able to develop and implement. So are there any plans around addressing that sunset date and the confines associated with it?
Yeah, that's a great question, and we recognize that going back through this reapproval process, the implementation wouldn't be until January 1, 2023, which we recognize is not ideal for anyone to only have 1 year and is not an incentive to stand up these programs. I think the administration is looking at this and trying to figure out the course of action forward on that sunset date and how it affects EMS around California, but we don't have an answer on that today.
Thanks.
Thank you. Further questions from commissioners? Seeing none, any in the members of the public? Please state your name.
Yeah. Hi, I'm Tanier Ami, the CEO of the CareStar Foundation. I just wanted to briefly follow up with the comments about the CP program. As many of you know, we are offering funding for new programs to come on live. And because of just the setback, we are changing that program just to ensure that it's, we'll hold it open as soon as folks are ready. It's going to be open on a rolling basis. So we appreciate that the timing is a little challenging. Just wanted to make that known.
Thank you, Tanier. Very helpful. Any further members of the public? Seeing none, we are moving on to the strategic planning update. Director Basman.
Yeah, thank you. So for strategic planning, we've talked about these two parallel paths that have occurred. One is that IMSA has completed our internal strategic planning process. We have signed off and promulgated a new internal strategic plan, which will be up on our website soon. Candidly, this is not about the California EMS system. This is not about EMS at large. It's about our department and our staff and how they want to see their organization move forward together in partnership, and how we want to streamline technology and communications and all those things. But obviously I want to make that known that we've promulgated this, and like the external strategic plan, we'll continue to update and iterate. And if there is any feedback externally, we'd love to hear that as well, in case we majorly missed the mark on something, but hopefully not. In terms of the external strategic planning process, well underway. I will just say thank you to everyone who is participating within it. I think we're getting lots of great feedback. In terms of the technical update, the advisory committee met several times. They were able to develop a draft mission statement, vision statement, guiding principles with definitions. We've now engaged with the working group meetings. For IMSA, those meet every single Friday for the next 12 weeks for 3 hours virtually. For the working group itself, the 12-week agenda in advance of everything. Every 2 weeks, they provide written feedback to everything that we're doing. And I think really what we're doing is two things. One, beating up what the advisory committee put forward. Where were our gaps in thinking through the vision and the mission and the guiding principles? What did we not see in our group? And then the second thing is to really dig in on the objectives and where we want to take the California EMS system. I think proposed objectives were put forward, but we're really digging into a SWOT analysis. What are our strengths? What are our weaknesses within the EMS system? Where are our opportunities? Where are our threats in the future of EMS in California? What can we assume to be true about these different work group areas? And so we're going to really dive into a level that the advisory committee has not. We meet again with the advisory committee every other month, so there'll be a bilateral transfer of information. We're reconciling everything from the work groups, taking that up to the advisory committee for consideration, discussion, working through it, and then sending information back down, questions, more consideration. So we have this great kind of back and forth dialogue, and folks who are closest to the work to be able to dive in on those working group meetings. So those will conclude by the end of December. And then in the first quarter of 2023, we will host a statewide listening session. So if you were on one working group but had interest in another, or you weren't on any working groups but you want to hear where it's at, we'll host it statewide. Anyone's welcome to join. We'll present the entirety of the California EMS system strategic plan and just hear comprehensive feedback, and then we'll work towards finalization with hope in the very first month of the second quarter for 2023.
Thank you, Director Bassan. That's a very big agenda and a big effort, and we appreciate you for it. Would you mind, for the public's benefit, to name the 4 subgroups and what they're going to be focusing on?
Yeah, so the first one, or just not in any particular order, we have administration and resilience. So kind of a two-part work group there. Specifically for resilience, what are the things that maybe are going to be threats and opportunities in the future, the California, the aging population or the frequency in disasters, and how do we think about that in resiliency forward and have mitigation strategies now? In terms of administration, how do we at EMSA make everyone's life easier, whether it be electronic submission of plans or whatever it may be that folks come up with? How do we streamline things and make it easier? So that's administration resilience. The next one is around data and innovation. And we have kind of two data work groups that we're trying to keep very separate, although they live together every day, which we recognize. The first data group is retrospective. How do we make sure that we have a data-driven, policy-driven EMS system, and really focusing on what data do we collect now, how can we better use it, how can we all come together around data to make good informed decisions that are policy that help move us forward. So not a real-time data conversation at all, very much a policy retrospective look at data, whether it be medical interventions, operations, etc. The other conversation is around real-time data and operational management. We've seen a lot of stress on the EMS system, not only during COVID, but also during fire season, APOT times, the flu, even today. And so what would enhance, the questions that we're pondering is what would enhance and change our lives around real-time data for EMS. And we know that this touches disaster management, it touches bed polling with hospitals, it touches mutual aid, it touches so many things, but it's a really large conversation that we're trying to have around, is there a way, and maybe there's not, but is there a way to enhance our real-time data understanding and support local EMS and all of the things that people are doing every day? And then our last working group is around equity and transparency. I think obviously we want to make sure that the California EMS system is equitable and is transparent. And so really focusing on questions like, should we have an equity framework? Should we all be analyzing equity in the same way? You know, how do we think about if EMS is equitable? It can be a response time, sure, but it can also deal with staffing and who the staff are and all of these different things and just culture. So really trying to dig into what is transparency and what does equity mean and where do we want to take it for the next 10 years. And all of this is a 10-year plan, and we plan to update it at least every other year, if not more frequently, and really operationalize it. So even whatever gets codified first quarter of next year will certainly change even 24 months later. Hopefully that's helpful.
Very helpful. Thank you, Director Basnick.
Yep.
Any discussion among commissioners? Yes. Commissioner Snyder.
Hi, good morning. I'm just wondering on the 14 groups that were invited to the subgroup areas, has that been published on who's on the subgroups and who's representing those groups?
I don't think it's been published on our website, no, but happy to share the information, absolutely.
If you could, that would be helpful. Thank you.
Yeah.
For the commissioners. Seeing none, any comments from the commission item? So we'll move on to agenda item number 6, EMS systems, and we'll talk about ambulance patient offload times presented by Tom McGinnis, EMS Authority Chief of the EMS Systems Division.
Apologies, you're going to hear a lot from me, but I think this is my last item for a while. So,
I apologize.
So obviously, as many of you know, and as we've talked about during several commission meetings, we had the ambulance patient offload time committee. We did conclude the committee on time, so very excited about that. And just for those of you either in the public or on the commission that participated in that, just such a huge thank you. It was tremendous and really proud of what came out of it by all of you. So just as a reminder, the mission of this committee was really to develop the advisory recommendations to the state, to CDPH, to EMSA, whether it be legislative, regulatory changes, operational changes, whatever that may be, to solve the APOT problem that we have here in California. And again, we wanted to make sure that all of the decisions kept the patient at the front. We wanted to make sure that that's really was our North Star as we walked through. So we gave, it was a 7-month timeline, very tight. We went through all the recommendations and we separated into 3 sections. I am going to briefly go through each recommendation because I think it's really important and it's going to be really important for the next 24 months, but I will be as brief as I can. We separated it into 3 sections. One was EMS based, recommendations. What can the EMS system do? The second section was hospital-based. What can the hospital system do? And then the third was just other. What can we do collectively? What's outside of even that? And really came together. And then each one was voted on, either endorsed or not endorsed by the committee. And then those were pushed forward, shared with the commission, shared with many associations, and shared with the legislature. So really quickly, I'll just walk through. This won't take long. So we're going to start with the EMS system recommendations. The first one was recommendation 1 for the EMS system was an electronic signature documentation. I'm not going to read the whole recommendation, but it really got at defining within our California EMS information system that we should have a requirement around electronic signature that captures the point in time when the hospital receives the notification of an ambulance arrival and when transfer of care is executed for documentation of APOT. Really just honing in on data integrity and codifying that standard. The second recommendation was around implementation of multiple options for patient transport. Obviously, with AB 1544, we're already seeing that take place and with pilot programs, but there was definitely a will in this recommendation to continue to build on those community options and have other destinations for transport and really explore that. The third one was promulgation of a statewide APOT standard. As many of you know, the local EMS agency has the authority to set what that standard of time is for transfer of care and offload. And so this would really create that bumper statewide for the EMS authority to set that standard. The fourth recommendation was enforcement by CDPH of EMTALA in coordination with EMSA. If you are to look at the APOT problem as a violation of EMTALA to patient safety. The fifth recommendation was advocacy to our federal partners around reimbursement for transport to alternate destination and really the sustainability of so many of these programs that so many folks are interested in and using. Our partners are using these every day to decompress our EMS system. How do we make sure that they have the reimbursement and sustainability that they need? Operational monitoring, which we just kind of talked about with real-time data, we certainly saw throughout at least the pandemic that, one hospital would be very much inundated and 4 blocks away a hospital might not be inundated. So how do we have that real-time data capturing where if someone can get care somewhere else that the ambulance and the crew knows where they can go and how to do that. So that operational monitoring of the system. Those were the EMS recommendations. In terms of hospital recommendations, there was a recommendation put forward to modify the legislation to allow paramedics to work in general acute care hospitals, not just those with rural designations, but all GACs. There was a recommendation, obviously, for the hospital system around increasing throughput efficiency by reducing door to first provider and APOT time. So just how inside the hospital hardened infrastructure do they reduce that throughput? That was voted on. Public data reporting, and some of these were not endorsed, just I do want to emphasize that the state should require general acute care hospitals to post emergency department wait times was an option that was put forward and voted upon. Recommendation number 4, the general acute care hospital should staff EMS arrival teams. This was based off the experience that we had during COVID when sending out APOT teams to hospitals that were very, very impacted and we're seeing significantly long wait times. We did see some success with that, so something similar here was put forward. Hospital reimbursement to providers. CDPH and EMSA should establish a joint oversight program which requires hospitals to reimburse ambulance providers for wait times exceeding the current standard. So you would see that bill rate at the current ambulance strike team rate for reimbursement. Rescheduling of elective surgeries. CDPH and EMSA should establish a joint program which requires rescheduling of elective surgeries for hospitals that are consistently not meeting those APOT standards. And then that concluded the hospital recommendations. For other, there was a recommendation put forward for development of the local APOT committees, requiring those and requiring the emergency medical care committee. So it would be a requirement of emergency medical care committee with an APOT committee as a subcomponent to that was a recommendation that was put forward by the group. Joint plans was the next recommendation. CDPH and EMSA should require the development of a joint LIMSA hospital surge plan. Health information exchange. Certainly, the state should require the LIMSA to use electronic platforms to improve communication to pre-register patients and really promote this health information exchange for expediency. Workforce development was a huge recommendation that was discussed, and how we collaborate and make sure that local EMS training programs and EMS providers should have these workforce development programs as subsidized by the state. We talked about a community ED RN training program to increase hospital emergency department registered nurse staffing by establishing and sponsoring these regional bridge programs to train these nursing staff. And then community education around how to use the 911 system and when to use the 911 system, what is emergent and non-emergent. And then finally, as many of you are aware, we have a toolkit on this statewide, and it was our last recommendation was a review and update of that ambulance patient offload time toolkit. So all of these recommendations were voted upon, and this package was moved forward, and I believe all the commissioners have a copy of the package.
Thank you, Director Basnett. That was very informational. As I recall, several of these were not endorsed. I do recall that the canceling elective surgeries was not endorsed. Not to put you on the spot, but do you remember the other two? I think it was a total of 3 that were not endorsed.
Yes. I think I have it. 1 second. So not endorsed was the public data reporting. Not endorsed was rescheduling of elective surgeries. And I think those were the only 2 that were not endorsed. Oh, I'm so sorry. Public data reporting, rescheduling of elective surgeries. Yeah, those were the only 2 not endorsed.
Thank you. And I think part of that was the recognition that elective surgery does not mean, superfluous surgery. It just means it doesn't have to happen emergently. And we learned during COVID that delaying surgeries causes bad patient outcomes. Any further discussion among commissioners? Any members of the public?
Good morning. Speak to you today.
Please state your name. Okay.
My name is Pam Allen. I was going to go there. I'm representing Redlands Community Hospital, an independent, not-for-profit, standalone community hospital. So, again, my name is Pam Allen. For the last 8 years, I've been the Director of Emergency Services at Redlands Community Hospital. I've dedicated my 30-year nursing career to serving patients who seek necessary medical care through emergency services. I have served at the bedside, as a mobile intensive care nurse, in trauma services, and now in leadership. I've had the privilege to work in several counties in Southern California, including San Diego, Orange County, and currently in San Bernardino County. In addition to that, I also serve as the co-chair of the California Hospital Association statewide EMS Trauma Committee. I believe that all EMS service providers and hospitals have a common mission. We want to provide excellent, timely, safe patient care. As you mentioned, ambulance patient offload times is a very complicated topic and multifactorial. Ambulance patient offload times, again, is complicated. While hospital emergency departments work very hard to get our patients offloaded and ambulances back out in the field, there are broader problems in the healthcare delivery system that do contribute to delays. As such, there are a myriad of issues that affect the effective transfer of care of patients to the gurney, the chair, or other acceptable locations. Many hospitals have a decreased emergency department and inpatient capacity. We have mandated nurse-to-patient ratios, increased patient acuity, high volume. We have a shortage of primary care clinics and providers, and we also have an influx of behavioral and mental health patients. We also have staffing shortages. In short, ambulance patient offload delays have become a public health crisis. I think we all know that. All we need to do is to work together to break down the silos. In September 2015, AB 1223 passed, gives a local EMS the authority to develop policies and procedures to calculate and report ambulance offload times to EMSA. A statewide standard of 20 minutes, 90% of the time was determined. While looking at the survey conducted in 2015, many felt that they wanted to question the study's validity based on the data collection and under standardized reporting metrics. Many variables to recognize, including geographic consideration, was not considered, and how quickly a crew walks through the ambulance bay after arriving at the hospital. Bottom line is we need to use the same metric standards. Part of that is to determine when does the clock start and when does the clock stop. As an emergency department director, I'm all about data. Data drives change. I look at a patient's arrival to when they're seen by a provider and time of arrival to when they're discharged or they're admitted. We start the clock when they're registered. We don't start the clock when they're out in the parking lot. Another area to acknowledge is the need for validated data. We need to ensure that data being reported by the local LEMSA is validated. Currently, the ambulance patient off-log times data is not being shared with hospitals. Until this happens, we need to maintain our current standard and establish framework. Lastly, the emergency department is a safety net for all medical care. The issues in the ED are reflective of the issues of our society and healthcare system as a whole. Despite the challenges, we are proud that we're there for our community, patients, family, and friends, 24/7, 365 days, no matter what. Let's come together around a unified vision. We need to share our goals, we need to share our priorities, and we need to collaborate to find a solution that is jointly owned across the whole system. We look forward to continue working together on this effort as we are committed to meeting our mission to care for all. Thank you very much. Any questions?
Thank you very much, and I think most of us here, all of us will agree with many of your points. Absolutely. Thank
All
you.
right, thank you.
Hi, good morning. I'm Rose Colangelo. I'm the ED Director at Sutter Roseville, representing Sutter Health. I'm also the co-chair for the California Hospital Association EMS and Trauma Committee. Thank you for this opportunity. Hospital emergency departments and emergency medical service systems are critical components of health care delivery network. They work together hand in hand to make sure residents can access needed emergency medical care 24 hours a day, 7 days a week. At Sutter Health, our emergency department personnel focus their work on delivering quality care to patients in the most efficient manner possible. Like all emergency departments, we aspire to get every patient seen quickly and release ambulance crews so that they can continue to serve the broader community. We have a history of working together with emergency management service agencies to reduce offload times by establishing mitigation strategies and increasing community awareness about the appropriate use of 911 calls. While we understand the motivation to focus on a 20-minute standard, and we share the collective objective to reduce wall times, we have serious concerns about the process by which the standard is being developed, especially since we have already established recommendations and a framework to help mitigate increase in all wait times. In 2014, a mutual agreement was established in a toolkit developed by the California Hospital Association in collaboration with the California Emergency Medical Services Authority. Together, these entities agreed to a 15 to 30-minute standard for 90% of patients transported to emergency department. What is critical about this standard, however, is that the agreement clearly stated that data collection systems that capture the metrics defined by this document should be developed as a collaborative effort between the LEMSA, ambulance providers, and hospitals. If the data is unreliable or the entities are not using the same metric measurement standards, then proposed future standards will also be unreliable and ineffective. Before moving forward with a specific metric, hospitals must have the opportunity to validate the data being submitted to the local emergency management service authorities. Too often, while assessing individual cases, discrepancies arise in the start and stop times. Reliable data is key to measuring accurate wall times and is very important in assessing whether our mitigation strategies are continuing to be effective. Data reliability can be achieved if all involved entities are able to review and validate the data. Any increase in APOT time is of concern, but we've already done the work between hospitals and emergency management service agencies to establish a framework to assess the data and implement mitigation strategies. We all share the same goal, to serve patients safely and efficiently and get EMS personnel back into the communities to serve those in need. Let's continue to build off this good work, maintain the current standard, and work together to use accurate data to improve our efforts. And just one more thing, just aside. I've had the opportunity to work in San Diego County for many years and then now work in Placer County. And last week was truly an example of when you work together, how you can make it work. And we had one of our EMS supervisors come in and say, "Can you look up this chart for me? I just don't think those times were right." And he was right. They weren't right based on what his crew had said and what we said. But it was really the work that John and I and our LEMSA and coming together and the work that we're trying to do in Sacramento, and how can we get together to really work together to make sure that we're a resource to our community. Thank you.
Thank you so much. I think we all agree that accurate data is important here. I would submit that the toolkit of 2014 did not yield the success that everybody was hoping for at the time, and I would also submit that EMS providers themselves are had to limit yourself to 2 minutes. I know it's hard to get your message across, but trying to stay on time. Thank you.
Thank you, Chair Uner and members of the Commission. My name is Kevin Green. I'm the EMS and Health and Safety Director for the California Professional Firefighters. I want to begin by thanking Director Bessnet and the EMSA team on facilitating a very thorough and transparent process during the work of the APOC committee. The representatives from the 16 organizations, stakeholder organizations, had months of robust discussion leading to the 17 recommendations forwarded for consideration and action. We all know excessive APOC delays continue to be a problem statewide, putting patients at risk and straining the EMS system. When ambulance personnel are required to remain on the wall for long periods, these delays of transfer of care negatively impact patient outcomes and cause ripples throughout the pre-hospital care system when ambulances are unable to return to the communities they serve in a timely manner. Further, excessive delays act as a tax on public agencies when personnel oversee care until they are able to transfer care to the appropriate facilities. In closing, I wanted to reiterate our appreciation for the EMSA staff on the work of the APOC committee, and CPF urges the Commission and EMSA staff to continue to work towards solutions to address unwarranted hold times in California. CPF stands ready to work with our partners and policymakers to implement meaningful solutions that prioritize treatment, patient care, and create efficiencies in the EMS system in California. Thank you.
Thank you. Any further discussion? Seeing none, we can move to the Community Paramedicine Pilot Project update presented by Lou Meyer, so Community Paramedicine Pilot Project Manager.
Mr. Chair, if you would, please.
Please.
There are still a couple other items on the APOD that I would like to go ahead and touch on real quick.
Please do.
Thank you, sir. So Tom McGinnis, I'm the Chief of the EMS Division for the EMS Authority. There are two other items on that item, the APOD item I want to touch just briefly. One of them is the quarterly APOD data submission by our local EMS agency partners in the state. This is something the Commission has asked to have kept present on the agenda moving forward. And so this chart is simply a reflective update of where we stand with commissions working with the local EMS agencies. We're very happy to show in this chart that if you look on the right side of it, you'll see the 2022 quarters and even into 2021, you see everything is green. We've had staff work with some of the local EMS agencies, and everybody has gotten caught up and current. I know that COVID caused a lot of challenges for different folks, and so we're now actually caught up into a more current time frame, which is something we're very happy to see happening. At your next meeting that will take place in December, it will actually be a reporting period where we will show data reporting for the quarters that went from June up through the current time. For item 6C on this agenda, APOT reporting memo. Something that we did early on in this is we worked with our local EMS agency partners to develop a schematic of how they would turn the data into us. This is largely a manual process at present. One of the things that we heard very loud and clear was they would like to see us take this data from our KIMSA system, our California EMS Information System, directly and be able to fill it without having to have a lot of paperwork done. Director Bassinet sent out a memo in July, and we have worked with the local EMS agencies that what's going to happen is starting at the first of the year, IMSA will be taking APOT data out of the KIMSA system. Between now and the time we actually start doing that, we are going to be reaching out and working with the local EMS agencies and trying to make sure that if there are abnormalities in things or things aren't lining up, that we have the time period in the next few months to make sure the data is in fact reflective. So there's still some work to be done in this arena. We have done work in the past. Our data unit has gone out into the field and met with some of the local EMS agencies, and that does do a lot of very solid resolve, if you will, to helping us make sure that we get the right information put in and that the data that we get into KIMSIS is actually reflective. So this will be a process change, and again, starting January 1st, it will be taken electronically. But with that, absent questions?
Thank you, Chief McGinnis. A quick question. I assume the correlation between the old way of collecting data and the KEMSIS way of collecting data is a good correlation?
Response to you, Mr. Chair. So the data is collected based on elements that are in the data system, so it should be populating straight across. Sometimes the factoring is a little different, and that's one of the things that we have found with working with the local EMS agents we've been able to correct. An electronic system at times may not really capture it the right way, and that's why some of the tweaks have to be done to make sure. But as far as the actual elements are written, APOT 1 and APOT 2, it should transition directly, sir.
Thank you. As we've heard, people are sensitive to accurate data in this topic.
Yes, sir.
Thank you. Any further discussion?
So I'm curious, LA County, if you look at their APOT reporting, 48% of records are valid, 68% of records are valid on the reports that I look at for LA County. What's the difference? I would like to see the difference or the problems that arise from what is KEMSA seeing and what's my LEMSA submitting, and how many invalid records are there? What's valid data? What's not valid data? What's the discrepancies? Will that be available to the commission to review? Because there seems to be quite a few invalid charts in LA County, and that's just one county that I could speak to.
So specifically regarding LA, currently LA County is not submitting their data to the California EMS information system, and we are working with them and working with the administrator and the medical director there to remedy that issue as quickly as we can.
So additionally, response back to Commissioner Snyder. Additionally, the answer is ultimately yes. We can try to look and figure out why some of those things are happening. And as I mentioned, that our data unit staff do go out in the field, and that's how we try to make sure that when we have those kinds of things, we're able to pick them out and work with them. So until we get electronic data submitted, as Director Bassinet just mentioned, it's a little difficult for us to say exactly what some of those nuances are, but we are working with that with the other local EMS agencies very well, I think.
Thank you. Commissioner Burrows?
Thank you. Certainly hearing a lot about data collection and what is considered accurate data. And respect the public comments that we heard today as well. Looking at recommendation 3 for the hospital requirements and the recommendations for APOT, recommendation 3 for public data reporting, which included a dashboard, was not voted to move forward as a recommendation. Can you speak to why that occurred, not being part of that committee, and some of the discussion of why that would not be a public dashboard for all to see for ED wait times?
Sure, I'll start us off, and then Dr. Garzon may be able to add as well from his medical perspective. I think a lot of the discussion that took place was a fear or a concern that if those public waiting times for the emergency department were published, it would be a discouragement to patients who truly did need the ED not to go. And I think we saw some of that delayed care where people were scared to go to the emergency department due to COVID or whatever it was, and then they delayed care, and then it truly ended up being a 911 emergency. And I think a lot of the discussion centered around if X individual sees a 48-minute or a 4-hour or an 8-hour wait time in the ED, is that going to be a discouragement for them to go? But Dr. Garzon, do you want to add anything to that?
No, I have nothing else to add. I think that was the gist of the concerns with the people that were not in favor of supporting that recommendation.
Correct. Having been part of that committee, I recall that we were concerned these numbers are easily manipulated by having a patient shake hands with a provider and then not rendering care for another several hours. And there's self-interest on part of hospitals basically advertising. So those were some other concerns.
Yeah, I appreciate that. Thank you. Was there any discussion about having any internal components for EMS providers and hospitals to be able to utilize that data and understand where wait times were and looking at other potential hospital destinations?
So I think there definitely was interested in that, and candidly, in our partnership with public health, when you see patients boarded on ventilators or boarded on cardiac monitors, you know that one could assume, rightly or wrongly, that there would be significant wait times within that emergency department. It wasn't put forward as an official recommendation, but I think it's something that we can take forward in our work over the next 12 months as we really hone in and focus on APOT.
Thank you. Further discussion among commissioners? Commissioner Gautreaux?
Yeah, just with respect to data, and in response to the representative from Redlands Community Hospital who suggested that, perhaps the clock should start when the patient is registered or at first contact with the provider. Having worked in emergency departments for 30 years, the time of registration is extraordinarily variable. And as a clinician, I've had delays in ordering CT scans because the patient wasn't registered yet. Same with triage. There can be up to 90 minutes to wait for triage in some institutions. So I think we have a uniform data source for arrival of the patient in the emergency department that is recorded by dispatch. And there's absolutely no reason I see to alter that metric.
Thank you. Commissioner, go ahead.
Thank you. Yeah, I just wanted to say, thanks to you, Director Bassett, and the team for your work around health information exchange previously and, ongoing. The establishment of that connectivity and that data transfer, I think, fosters transparency and clarity around what's going on, not just in terms of, patient care, but where they are in the continuum and ultimately where the outcome ended up for that particular individual. So, appreciate the commitment not only to, continuing to bring those exchanges up, but also to find ways to fund the ongoing operations and maintain the ongoing operations of those systems that have been established. I think this is going to be a key way that we share information in real time, and we do it transparently.
Thank you, Commissioner Kuzman. Any further discussion? Go ahead.
Thank you. It's been very informative. Again, I do want to say, as running a small rural hospital, as well as the ambulance company, we have to work together to solve this. And if we get into finger pointing, we're going to be talking about this in 5 years. So, seconding what Dr. Erner said earlier, I mean, we're all part of the same team here. So I understand the comments from both sides, and it is all about patients, but we're all in this together, not fighting each other, hopefully.
Thank you, Commissioner Suber. Well said. Seeing no further hands raised, we can move on to Lou Meyer, who's going to be giving us the Community Paramedicine Pilot Project update from Lou Meyer, Community Paramedicine Pilot Project Manager.
Thank you, Mr. Chair. For the record, my name is Lou Meyer, and I am the Authority's Community Paramedicine Pilot Project Manager Consultant. As of today, there are 11 active pilot projects ongoing. One is basically on hold due to a injury of the only paramedic that they had in Alameda City. And the data continues to show that we're averaging about 175 new enrollees per month through the last quarter, and that's through June 30th. The official report for this data will actually come out by the end of September, or the end of this month, but I wanted to make sure that you had the most up-to-date information. This data includes the San Jose project, or Santa Clara project, for the month of April, but not May and June, because they closed down their pilot project during that period of time. But we're showing total enrollment for the projects total is 15,288. Again, I'm pleased to say that 15,288 enrollees without an adverse outcome of any of them. So kudos to the pilot projects, the quality care through their lenses and review and so on and so forth. I'm sad to say that this data does not include the City of LA. We continue to have problems with the City of LA submitting data, and as hard as I try, this report does not include data from the City of LA. So I need to let you know that. In reference to the other things that I'm doing, I'm working very closely with the EMSA team and working with the toolkit development and the preparation for a workshop, and as everybody knows, the workshops had to be bumped until December. And again, we have all the stakeholder groups together to help make this a very productive workshop and a toolkit to move this project forward. And I'm also very conscious of the January 1st, 2024 date, and I wake up in the middle of the night thinking somebody wrote that down wrong, because we're not quite there yet. But I think the effort's there, and we'll continue to push this down the road. So with that, I think Director Bassett kind of covered everything else I had on my page here, so I don't need to I don't need to go into that again. But everybody is working very closely together, stakeholder groups and EMSA to bring this to fruition.
Thank you, Mr. Meyer. I will bring your message to the Los Angeles folks. Any discussion among commissioners? Commissioner Dunford.
Yes, thank you. Are we working with the National Sobering Collaborative to define what a sobering center is? As you know, that's one of the 3 ways that a center can accomplish the criteria to become a sobering center. And it might be worth us reaching out to them. It's a very active and growing group across the United States that are coming up with 10 different definitions of sobering centers. Everybody has their own version of a sobering center, and I think that, I'm not sure if the organization understands its significance within the bill itself, that they too can also define what a sobering center is for California.
Well, there are options of how you become recognized as a sobering center in the regulations, and the national is one of them. But I'm not too sure we've built any criteria at this point.
I would just recommend that, because I participate in the National Sobering Collaborative, and I can tell you that it's a loose association right now. It's not, doesn't really have the structure. They just got their own executive director for the first time. But as we kind of look to that organization for guidance, I think it would be a good idea to involve them in this discussion.
For the record, Tom McGinnis, Chief of the EMS Division, again, response through the chair, Dr. Dunford. So one of the things that is going on nationally, as you mentioned, these committees are getting a little hotter, and they're starting to light up, and they're getting seeking involvement through other activities that I have with the National Association of State EMS Officials, specifically in the data arena. I was contacted, in fact, just last week, asking to engage a little bit and start trying to see what could be done or what interest we might have as a state. I don't know exactly what that means yet. The first meeting is not until sometime in early October, but what I will do is make a note to keep the commission informed of where that goes as we move forward.
Thanks again. I think it's a good idea. It's extremely difficult sometimes to recruit a 24/7 nurse to be able to work and bear some discussion with the people who are actually currently doing this. Thanks.
Thank you, Commissioner Dunford. Further commissioner discussion? Commissioner Thompson.
Excuse me, I have a question. Is the December 8th and December 15th workshops, is that going to be, excuse me, posted on the EMSA website so everybody knows how to register and when? And
Response to the Chair, Commissioner, the answer is yes, it will be. The registration process will be basically exactly like the ones that we had anticipated for this time period. It will be done through Eventbrite. The locations were firmed up within the last couple of weeks, and we have a couple logistical things within the department we're working on. I anticipate that by the end of next week, the registration link will be up and available.
thank you.
See no further commissioner hands up. Any members of the public wish to comment?
Thank you. Good morning, Commission members, EMSA staff, and guests. My name is Ray Ramirez. I'm from the Ontario Fire Department and also part of California Fire Chiefs EMS section. And this is just a general comment on the program, because I think there's some opportunities here that we can take advantage of. The regulation process has been long and various viewpoints expressed on it, but what I look at that is it helped us focus the discussion on a framework for what community paramedics can be and brought everyone up to a certain level. And that level now, many of you know, related to the APOT discussion and the other issues that are going to come up, the EMS system's been stressed. The personnel in the system are at the breaking point. The attrition rates for both public and private agencies are very high. The new hire applicant rates are very low. We need to fix things, and the COVID pandemic gave us that opportunity. The governor waived certain restrictions. The federal government provided funding where it wouldn't otherwise be there. They also waived certain restrictions, and it allowed some of the LEMSs to develop programs that were outside the general scope of the community paramedic regulations. I think many of those programs are valid, that we should come together as a group, identify any gaps, identify the things that worked, and then that process is going to sunset, roll those into that process so that we can develop a community paramedicine program that relieves the stress of the EMS system, that relieves the stress on the hospitals, that relieves the stress on the providers in the field, both in the emergency room, on the fire engines, and on the ambulances. If we don't do that, I think we waste an opportunity here, because absent the pandemic, we would have never had those things, or they would have taken years to come forward. So what my challenge to the group is, can we come together? I know there was discussions yesterday. I saw the appetite for it, but we have a short timeline to get the regs passed and make those identifications, and I would ask that we all come together to make those recommendations to help improve the system. Thank you.
Thank you, Chief. Any further members of the public? Let's move on to the next agenda item, cessation of 180-day extensions for the submission of local EMS agency annual plans.
Mr. Chair,
Chief
Tom
McInnes.
McGinnis, the Chief of the EMS Division. When the COVID pandemic hit, the governor allowed some executive orders that allowed Dr. Duncan, our director at the time, to make some exceptions to policies about different things because of the dynamic of response and the stresses that were put on the EMS system, not just within IMSA, but our local EMS agency partners, as you all very well know. One of the exceptions was the ability to put in an annual plan. We waived a period of time so that they could have more time to be able to try to stay current. With the executive orders going away, the authority is in a position we have to go back to, I'm going to say, a little bit more business as normal with the planning process. We submitted a memo out not too long ago where we basically have informed the local EMS agencies that we need to bring everybody current and work through to get plan submissions that are in line with the current time frame. We completely understand there were some dynamics that just frankly couldn't be helped, and we do want to work through with them and not just get their plans in, but for us to approve plans and us to move plans from our arena so that they also have their approved plans for their local needs.
Thank you, Chief McInnes. Any discussion among commissioners? Seeing none, any members of the public? Seeing none, we will move on to agenda item number 7, EMS response to behavioral health patients. This I will be presenting. It's been near and dear to the commission. It's been a standing agenda item that's not to be, it's always a separate agenda item, can't be rolled into the consent calendar. We don't have a huge update now, but I've asked Commissioner Miller to give a brief announcement of what is going on, and we're going to present the next time.
Sure, thank you so much. Yeah, last meeting you heard a synopsis of some of the highlights of policies and procedures among LEMSs regarding behavioral crisis. So to make that more of an actionable thing now, what can be done and what I'll commit to doing as the chair of the School Practice Committee of MDAC is to put together a draft framework and sort of to highlight those things. I mean, I learned a lot by doing that project for you all for last meeting, and I think what I learned I can put together in a way to highlight the things that seem to stand out among some of the protocols and policies that we reviewed. So what we can do is sort of reverse the process a little bit with the School Practice Committee. Normally, that committee receives requests from LEMSs to adopt procedure or a drug for clinical practice in that LEMSA. And then we review it, discuss it, and then make a recommendation to EMSA. In this case, we can reverse it by putting together a framework that would not be prescriptive to a LEMSA, but that would highlight what we would then collectively believe to be, it's an overused term, but best practices that we discovered, in that review from last time, and pose that as content that might be usable by any LEMSA. Operationalizing it would be individualized, of course, but the pharmacology, and the content, the behavioral science content could be standardized a little bit. So for the scope meeting in December and before this meeting in December, I'll put together that framework. We'll discuss it at scope with MDEC and reach a consensus with which we might make a recommendation to EMSA as content for LEMSAs on behavioral crisis. So we can make actionable our discussion last time by doing that, and that'll put some information in the hands of the LEMSAs to do the best they can with patients in crisis. So with that, I'll pause and see if you have any questions.
Thank you, Commissioner Miller. Any discussion among commissioners? Any members of the public?
Thank you. Again, Ray Ramirez, Ontario Fire Department, California EMS Chiefs, EMS section. This process that we're talking about here, this mental health issue, is part and parcel to the community paramedicine program, and so I would urge that all our efforts be in lockstep with that. Also, just awareness: there was a bill passed that created mental health courts in California. EMS is an intake to that process, and what I would be looking for somehow is what guidance would we have and how can we leverage that or work in harmony with that with the programs that we're doing. I know that the process is being developed, and I would just hope that when that process is being developed, that members of the state or whoever needs to be involved would help guide them to make sure the EMS system is properly reflected in the development of that process. So this again is these types of incidents are a stressor to both EMS, hospitals, and law enforcement. We really need to take a deep dive and try to get all the programs that we have in sync and working in harmony. Thank you.
Thank you, Chief Ramirez. Whoops. Does the EMS authority have their fingers on the pulse of that mental health court thing?
I mean, I think obviously that's those are all in discussions of how that's going to work and how it's all going to roll out. And I think we're very much a part of those discussions within California Health and Human Services Agency. Agree that all of this is part and parcel together and needs to be unified as we move it forward. Don't know that we have all those answers quite yet, but I think committed to continuing to bring it forward and talk it through with Dr. Miller and others.
Thank you so much. It'd be really helpful to keep the commission updated on that as well. Thank you.
If I could just make a point, I think the frequent users community paramedic programs will have particular value in terms of providing the kind of input, because many of these programs probably were responsible for stimulating discussion about the need for these sorts of courts. So I think that you're right. I think that our frequent user EMS programs will be a rich source of experience in how this thing should run correctly. I know in San Diego's case, I know we ran into the barrier of not being able to deal with people who really needed, for example, conservatorship, and EMS is in a unique position to identify those people in the community in collaboration with law enforcement and mental health systems.
Thank you, Commissioner Dunford. Any further discussion? Thank you, Chief Ramirez, for bringing that up. We will move on to agenda item number 8, EMS personnel. First is the Contra Costa buprenorphine trial study. Will be presented by Kim Liu, EMS Authority Chief of EMS Personnel Division. And for the commissioners, this will be an action item. There will be a vote on this.
Dr. Chair, Louis Brunke, Chief Deputy Director of EMSA. Unfortunately, Kim Liu was not able to attend today, so I'll be providing the report in her place. I'll begin the report with the Contra Costa buprenorphine trial study.
In September 2020, the Contra Costa EMS agency began a pilot trial study using paramedics to initiate medication-assisted treatment, or also known as MAT, for patients activated in the 911 system with an opioid use disorder by administering buprenorphine. This program was incorporated into a multi-agency initiative with the California Department of Public Health to provide medication-assisted treatment, to share electronic health record data, to leave naloxone behind with friends and family on scene, and to utilize an EMS-designated overdose receiving center, the Contra Costa Regional Medical Center. The buprenorphine inductions were successful for primary withdrawal, and those reversed with naloxone. There were no patient adverse reactions. However, the study has yet to identify whether the trial study hypothesis that EMS buprenorphine administration to patients with an opioid use disorder in a pre-hospital setting will increase patient access and long-term intervention to treat opioid addiction. As such, it is recommended that Contra Costa extend its pilot project to include additional data collection as identified in the memo provided to the Commission. If there are no questions, I'll turn this back, the floor back to you. Thank you. I believe the commissioners have access to the buprenorphine trial study. Any discussion among commissioners? Commissioner Relucia.
Can you hear me?
Yes.
Yeah, so I have a couple of questions. So I'm just wondering, what does the extension of the trial period, I guess, what's the end point? Because we know that opioid overdoses are now, like, they're a big public health emergency, outside of communicable diseases. It's pretty much in the forefront of, public health officers' thoughts across the state. So I'm just trying to understand, by doing this extension period, does that mean you would do this extension period and then eventually it would become a local optional scope of practice?
If I can respond to that. So I'm Hernando Garzon. I'm the acting medical director for the State EMS Authority. And yes, the proposal to extend the study would be to gather additional data and information on patients. Although discussion with medical directors in MDAC yesterday, of course, points out that even as a local optional scope, part of that requirement could be for data collection and further information. So the data can be gathered that way as well. I believe that, at least from the medical direction point of view and the EMSA point of view, we can support either continuation of the trial study or transition to local optional scope, as long as there are requirements for data collection and sharing.
Thank you.
Thank you, Dr. Garzon. I'll speak briefly. Our choices are today to either stop the application, the use of buprenorphine in EMS altogether, to extend the trial study for another 180 days, is that correct? Or to move it straight to the local optional scope of practice. Local optional scope of practice would mean that every local EMS agency can apply for this program to give buprenorphine in the field, and then the scope committee can decide which data points they need to collect. A trial study, as I understand, is more involved. And so I've read through this, and my question is similar to Commissioner Relucia: what is the end point? If our measure of success in a buprenorphine application is to get a patient into a 30 or 90-day treatment program, that is by nature of the disease going to be a low percentage, right? People go in and out of treatment, they flunk out of treatment, they take several times before they decide to go into treatment. I would urge us to think about buprenorphine, which takes away symptoms of withdrawal from the patient immediately and has very little medical risk to it. I think everybody agrees on that this is a low-risk medication. We haven't seen any adverse effects. We don't measure the success of treating COPD patients by measuring whether they go into a smoking cessation programs, right? We don't measure the success of our chest pain treatments by measuring whether patients changes their lifestyle and stops smoking and eats better and starts exercising. So I think just relieving suffering on the spot and giving that person a chance to maybe get their act together for a day or two, sleep in a proper bed, recontact their family, that alone should be a good outcome in my book. Just relieving suffering. We do that with many other medications. Giving pain medications in the field does not change the outcome one bit, but it does change a patient's experience. I am concerned we only enrolled 47 patients in this. That's a very low number, but it is being used across emergency departments in many, many settings, and I would argue it's a safe medication to use. I spoke with Dr. Kim Freeman from the Tuolumne Local EMS Agency, and when we think of EMS agency, think of big buildings with many staff. She runs her EMS agency with 1.2 full-time equivalents. That's 1.2 people running the entire EMS agency, all of whom have other jobs. They cannot sustain further trial studies. So if a trial study gets extended, they cannot implement it in their LEMSA. If we push it into LOSOP, they can implement it in the LEMSA because they can comply with the data reporting required from a local optional scope of practice. In those rural counties that have little financial means, overdose deaths have gone up. In Tuolumne County, I'm told, fourfold. So there's a time to study and there's a time to act, and I believe that right now is a time to act. Even we're going a bit on a limb with 47 patients enrolled. I'll grant that. That's my speech on that. Thank you. Any further commissioner discussion?
I would agree. I think it's a very small number. I do say, as a medical director now of a substance treatment program, that I am encountering, especially with fentanyl, an increasing number of people with precipitated withdrawal. And the timing of the administration of Suboxone to somebody who is really significantly dependent is changing. We encourage 48 to 72 hours of withdrawal before we actually implement Suboxone-type drugs in most patients that are really addicted. So an accidental overdose is one thing. A guy who unintentionally takes a drug and he's not really dependent upon it, that's different than somebody who's been, using a gram of fentanyl a day, smoking it. And so I think that 48 patients is a small number, and that we didn't have any bad outcomes is only reflective of the fact that maybe only happens 2%, 3% of the time. But for those people who get precipitated withdrawal, it's a big deal. And so I think that we should be careful about adopting this prematurely, because the timing, the criteria, the way you measure somebody's degree of withdrawal is complicated, even for programs that run withdrawal management programs. So I think this is absolutely in the right direction, but I think we would need more data, and I'd like to see the number of patients that re-overdosed within a week, the same person who re-overdosed, and some other measures that EMS ought to be able to identify to find out whether we're really staving off what we're really most worried about, which is the next overdose is going to be a death. So linkage to medical examiner data would be really, I think, simple and easy to do as another metric of whether or not we're really succeeding. I mean, I know in my own system we'd have 1, 2, 3, 4, up to 7 overdoses in a single individual. And the question is whether we had actually impacted them. If we could show even a reduction in those repeat overdoses, that'd be another important outcome.
Thank you, Commissioner Dunford. Other discussion among commissioners?
Yep. I have just kind of a question, observation. If we're voting, I don't feel I have the information on pros and cons of a trial versus local optional scope of practice. Having missed MDAC yesterday, I wasn't in on that discussion, and so it doesn't look like we're only voting on to continue the trial. Is that correct?
Correct. Our choices are to stop the trial completely, to continue the trial, or to stop the trial and move the intervention into the local optional scope. If someone from EMSA could comment on the difference between local optional scope and trial study.
So this is Hernando Garzon again. The trial study regulations indicate that it has to be done under an approved trial study, which already exists, obviously, since it was approved 18 months ago, and that data needs to be collected, specified in the trial study, and that the local medical director needs to provide that data to commission at 18 months, which is where we are with the first part of the study, and then if it's extended, at the next 18 months. And that data then is used to make that decision about whether or not the the trial study would be continued or moved to a local or basic scope. The difference with local optional scope, the commission is not involved with that process when LIMSs apply for approval for local optional scope. It falls on IMSA and to approve and the scope of practice committee, the MDAC scope of practice committee, to recommend approval of that local optional scope. And there's no pre-mandated requirement that data be included in the local optional scope, but the scope of practice committee has the option, I believe, to require certain data elements be collected and reported back for reapproval when it comes up for reapproval again. So the commission would not be involved for the applications or approvals of local optional scope.
Thank you, Dr. Garzon. Commissioner Gautreaux.
Yeah, I would, in response to Dr. Dunford, I agree that there, with every therapy that we do, there's some risk. If we give epinephrine to anaphylaxis, there is some risk. I think that the data in this study and the data in the use of buprenorphine strongly supports that the weight of risk is in favor of using buprenorphine, even if there is a small number of patients who have precipitated withdrawal. Those patients can also be treated. So I would strongly support moving this to local optional scope of practice at this point and continuing to collect the data, which should actually give us a better idea of how often we're doing that.
Thank you, Commissioner Gautreaux. Commissioner Pierce?
Hi, yes. I'm in agreement with some of the statements that are being made here today, that clearly we want collaboration and clearly we want to be moving forward with the progress for our first responders. And so on behalf of that group, I think that we should be looking at this as a local optional scope of practice because our first responders are impacted with this on a daily basis. So I concur with the majority of the conversation right now that we do consider that at today's vote. So thank you.
Thank you, Commissioner Pierce. Commissioner Kuzma.
Thank you. I think a public health and medical approach to this particular challenge that our communities are facing is really important. And, one of the ways that we support that is we get to patients early. And I think, the way that this pilot has been, set up is to provide patients who are in need of this treatment with access to it early, with, connections, but also the opportunity to receive ongoing care. And so I agree with the majority of this discussion, too. I think, moving it into local optional scope makes sense. I would point out, specifically that in doing so, should a local EMS agency choose to adopt that local optional scope, the care and the quality is not only reported up through scope of practice committee and MDAC, but is also overseen by a highly qualified emergency medical services physician that's embedded within the EMS agency. One of the other things I wanted to point out about the structure of this program in Contra Costa in particular is that, there was essentially a local advisory committee and the representation on that committee was fairly broad. And so I would imagine that, any LEMSA that would move forward with the local optional scope in this regard would consider utilizing a similar sort of, steering committee to assure that all the connection points are there and that, the use is supervised and safe.
Thank you, Commissioner Kuzman. Further commissioners?
Well, I'm not against the idea of giving Suboxone in the field. This is Dr. Jim Dunford. I just, and maybe for lack of knowledge of all of the specifics of the Contra Costa project, I don't want to say that they didn't do everything correct. I just point out the critical importance of the linkage to doing this, and I would hope that any LEMSA would take a deep dive on this one if they chose to implement this, because I think it is important, but the continuity is as important. Suboxone is also sold on the street. It can be a drug of abuse. It has to be taught properly. Everything about this drug, and so I'm not adamantly against. I certainly don't want to take it that way, but I just think that the key thing is that this cannot just be an administration of a drug with a hope that somebody's going to go to a clinic in a week. That's just not that isn't the way that this should operate. We should have a higher standard than that, and hopefully there will be standards for LEMSs that want to choose to go this route.
Thank you, Commissioner Dunford. Commissioner Miller.
Yeah, I can assure everyone that if this makes it to scope of practice, that these very issues are exactly what the conversation would be. We had a long conversation yesterday with MDEC that goes to both the pharmacology as well as the behavioral science behind trying to find a patient with opioid use syndrome or disorder trajectory toward recovery. So, we have a lot of the scope committee has opportunity to consider all of these things and then to enact, through LEMSA, whatever data requirements we'd like to add, outcomes, other things. So saying that, I'm going to make a motion that buprenorphine be moved from trial study status to local optional scope of practice status.
Thank you, Commissioner Miller. Before we look for seconds for that motion, any members of the public wish to comment on this topic?
There have been some emails on this particular agenda item from the public, but before I do this, I want to make sure I'm pronouncing this properly. It's buprenorphine? Okay, thank you. I'm not a doctor. I have played one on stage. Okay. This is from Christy Koenig. Christy Koenig, Medical Director of the San Diego LEMSA, and is speaking today in support of moving buprenorphine trial study into paramedic local optional scope of practice. Opioid use disorder has reached crisis levels with unprecedented numbers of opiate overdose deaths. Our friends, neighbors, and family members are dying from the preventable disease. I communicated with our medical examiner last night, and for San Diego County alone, he reports preliminary these numbers for 2021. 1,302 accidental drug toxicity deaths. Of those, 877 due to an opiate alone or with ethanol or another drug, and of those, 812 fentanyl deaths. This represents an 867% increase in fentanyl overdose deaths in the last 5 years, and over 2,360% increase in the deaths due to fentanyl since 2016. Data from the first quarter of 2022, pending confirmation, indicates that we have 13.7% more fentanyl deaths than we had in the first quarter of 2021. Pre-hospital I did it. Thank you. Is safe, and it is effective at providing immediate relief to patients experiencing severe discomfort from opioid withdrawal symptoms. People are dying needlessly, and we need all hands on deck to reduce suffering and initiate a suite of life-saving measures to mitigate the opiate epidemic. San Diego is supportive of immediately moving this medication into the local optional scope status to provide the best access for this tool for implementation in communities across the state. The patient-centric action supports the EMSA mission to prevent injuries, reduce suffering, and save lives. She later wrote again to add, it is likely that to get more data from the local optional scope of practice than a trial study, as more LEMSAs will participate.
Thank you.
Good morning, Mr. Chair and fellow commissioners. My name is Brian Hartley with Boundtree Medical. I was a former paramedic back in the 70s and 80s when the earth was cooling, and we dealt with China White heavily in Richmond and Berkeley. I ask all of you to support moving this to a local optional scope. Right now, the numbers, those of you that know me, over 100,000 opioid deaths throughout the United States last year, 6,843 here in the state of California. Coupled with that was 46,000 suicides, many of which were coupled to overdoses. I would ask of you, here we're putting $55 million towards Cal Hope on the behavioral side, $150 million to sustain that program. This is part and parcel. We need all of you to work collaboratively as you have, and we applaud your support. Thank you.
Thank you so much. Other members of the public? Seeing no further, Commissioner Miller, would you restate your motion?
Sure. The motion is to move buprenorphine from trial study status to local optional scope of practice status.
Need a second?
Thank you, Commissioner Miller. Is there a second?
Second.
Commissioner Gautreau, second. We'll come into a vote, and I will call the roll. Commissioner Brown.
Aye.
Commissioner Burrows.
Aye.
Commissioner Dunford.
Aye.
Commissioner Gautreau.
Aye.
Commissioner John Domenico.
Aye.
Commissioner Gordon is absent. Commissioner Kuzman.
Aye.
Commissioner Lamb.
Aye.
Commissioner Miller.
Aye.
Commissioner Oshita.
Aye.
Commissioner Reluccio.
Aye.
Commissioner Pierce.
Aye.
Commissioner Snyder.
Aye.
Commissioner Suver.
Aye.
Commissioner Thompson.
Aye.
And Uno votes yes. So that's a total of 16 yeses, if I counted that correctly. No ayes. Motion passes. No nays, sorry. Motion passes. Thank you for that discussion. It was very, very helpful. And just by sheer likelihood, there are some people in this room who are personally affected with opiate use disorders. So that was a good discussion. I appreciate that. Agenda item number 9, Disaster Medical Services, presented by Craig Johnson, EMS Authority, Chief of Disaster Medical Services Division. So I keep on getting this wrong. Correct, the NRMT pass rate. Sorry, that was lost in my notes. I apologize.
Thank you, Dr. Chair. The National Registry EMT exam pass rate report spans a period of 2 years due to the COVID-19 pandemic. California continues to have the highest number of National Registry EMT certified EMS professionals nationwide. As of September 7th, 2022, there are just over 40,000 National Registry EMT certified California EMTs, AEMTs, and paramedics. Although California paramedic pass rates decreased during the 2020-2021 year, EMT pass rates increased. Overall, California EMS training programs graduate first-time pass rates continue to exceed the national average pass rate. And this completes the EMSA EMS personnel report, and EMSA is happy to answer any questions.
Thank you so much. Any questions from commissioners?
I just had one again. I just wondered, is there anything out there on best practices for, there's big variations, right? Some have 44% pass rate, some have 90% pass rate. Is there been any best practices for training centers that have low pass rates? Like what are the others doing that are having such high pass rates?
Thank you very much for that question, Commissioner. What I would propose is that I take that back to Kim Liu, who looks very carefully at these issues, and allow her at the next commission meeting to report out on just on that question of best practices for in regard to the pass rate.
Thank you. Commissioner Kuzman.
Yeah, so, similarly, taking a look at this, data, certainly we're above the national averages, both for EMTs and, paramedics, which is commendable. If you look at the last couple of years that, overlay with the start of the pandemic, though there is a significant drop in the paramedic pass scores. And so, I would be interested as to, whether or not there's any understanding of why those scores have dropped, because as we, stare down a path, which others have spoken about here, of challenges in, recruiting and hiring paramedics, particularly new graduates, which I would imagine these pass rates are tied to, because we don't require a registry for ongoing certification in this state, just initial, that having some understanding of why those those are dropping so that we can hopefully work towards getting them to increase closer to that, 83, 84% pass rate we'd seen in the past would be something that would be worth our time and effort.
Thank you, Commissioner Kuzmin. Further discussion among commissioners? Any members of the public?
Good morning, Commissioners. My name is Amanda Ward. I'm the Paramedic Program Director at Crafton Hills College. We were the first community college in the state of California to receive accreditation and have been running at a very healthy pace for the last 40 years. I would just like to reiterate the point that was already made in that those statistics and first-time pass rates are very much connected to the pandemic and what many of our institutions were required to do. I flew home from Sacramento and was told I had a week to take our completely in-person program and slide it into an online format. We saw our attrition triple across those 2 years. We have rebounded and are running very successfully again. So I would like to estimate that we will see those numbers increase. Crafton has an extremely high first-time pass rate, and it's secondary to the instruction that we have been able to give. So I am hopeful and very confident that we will see those numbers rebound in the next few years. Thank you.
Thank you very much. Any further members of the public? Then I would just like to make one point of correction. The prior motion passed with 16 yes votes, 15 yes votes, 15 yes votes, and 0 nays. I think we're at agenda item number 9 now. Disaster Medical Services Division with an update from Chief Johnson.
Yes, good morning, Mr. or Dr. Chair and members of the Commission. Again, I'm Craig Johnson. I'm the Chief of Disaster Medical Services Division for the EMS Authority. And this morning, I would like to share with you our, briefly our current activities for the COVID response, as well as for fire season. And then additionally, I'd like to share with you some high-level takeaways from our 3 after-action conferences that we had for COVID-19. The 3 conferences that we had, we conducted one down in the southern part of the state. We also conducted one in the Sacramento area. And then we had a meeting virtually, primarily with our California Medical Assistant Team member leads. So with that, current activities for COVID, we are continuing to support, and I would say a very limited number of monoclonal antibody infusion sites. However, we are in the process of turning over state-supported sites to local jurisdictions where continued use of those sites is needed. We're also continuing to process still out-of-state requests for medical staffing. But I will say that our focus right now when it comes to COVID is primarily on recovery. We're spending a lot of time and effort on the retrieval of biomedical equipment, primarily ventilators. We're working with local jurisdictions and medical facilities on the retrieval. For fire season, I will tell you that we are well prepared to support any medical needs for fire. Since our last EMS commission and for this fire season, I will tell you that we have already been providing support at CAL FIRE and federal base camps to provide medical care for firefighters. We've actually provided support for the Mills and Mountain Fire. We provided support for the Fairview Fire. We've also provided support for the Mosquito Fire, which we are currently still supporting. Now, as I mentioned, we did hold several after-action conferences. We all know that the last couple years have been long and challenging, and the response just very significant. And I can tell you from those conferences, there's some high-level areas that I will focus on today, but just let me iterate to you that obviously I can't cover everything. We'd be here all day. But I will give you some high-level takeaways. And primary focus areas include patient movement, medical staffing, healthcare surge, medical equipment and supplies, and an overall, effectiveness of the medical health system, kind of an assessment of the effectiveness of our medical health system throughout the COVID response. So the first one, statewide patient movement. And I will tell you that the patient movement plan, which we put in place in 2018 in collaboration with many partners, up and down the state, including federal partners, proved to be, quite a good framework for California. Having said that, though, the plan really did not address a slow-moving MCI of a pandemic with hundreds of interfacility transports, over a period of several months. However, I will say that we did come up with some solutions, although the patient movement plan really didn't address this, and one of the things that we did was kind of develop a hybrid approach, where we, medical facilities continue to utilize interfacility transport, but in coordination with our med health system that is working with the medical health operation area coordinators, the regional disaster medical health specialists, working with the state, as well as the state putting in place the All Access Transfer Center, working with them via contract to help with the coordination of patient movement, placement of patient movement. So I would say the patient movement plan served us well, but we do recognize that there are some areas that we can improve on. Also, with statewide patient movement, the lack of statewide bid polling or having a statewide bid polling system was challenging for us. Of course, we conducted bid polls all the time, but when we received the data, and by the time we needed to place those patients, that data was already outdated. So that's an issue. The public health order for level loading helped to encourage hospitals to accept COVID patients. Although the number of successful out-of-county patient placements, it remained low, primarily because of capacity. Some of the improvement items around statewide patient movement include updating the patient movement plan to include interfacility transfer ICU patient transports, level loading considerations, the process for regional coordination using transfer centers, and pandemic response considerations. Also, continue to investigate better methods for real-time statewide bid polling and strengthening communications at all levels. This includes, having clear processes, eliminating gaps in information sharing. And we all know anytime we have a response to disasters, communications is always one of our challenging areas. But I would say overall, communications, were very strong, but we do recognize that there's many opportunities for improvement. The second high-level item that I would like to bring up is state-level medical staffing. The state utilized, this was an issue that was brought up, and this is the state utilized the long-established disaster healthcare volunteer system to recruit and coordinate the new Health Corps program. Although this was a successful approach in bringing in large numbers of Health Corps members for their program, it did cause some confusion with local coordinators with utilizing the disaster healthcare volunteer system and for Medical Reserve Corps coordinators. We have disaster healthcare volunteers who are unpaid registering through the DHV system, and Health Corps members registering through the DHV system. They are paid at state level, and that created some confusion. How do we differentiate between the two? We did put some improvements in place as we went along, and we did find that, by the end of, well, we're not really at the end yet, but to this point, we have managed to deploy over 7,000 Medical Reserve Corps members and DHV disaster healthcare volunteers. So with the work that we did to kind of improve the system, we were still able to utilize the system at the local level, but it was brought up as problematic. We also approved and processed over 73,000 out-of-state medical personnel waivers to support medical facilities across the state. Another really huge success for California. However, it was brought up, though, that there was some confusion regarding state contracted rates versus locally negotiated rates and who was paying for the staffing. I will say I think this issue kind of resolved itself over time as we went on in the response, but it was a point that was brought up. Additionally, the use of contracted EMS personnel, a state National Guard, and federal medical teams proved very successful, but these resources became increasingly scarce as the pandemic wore on. And we already talked about the ambulance patient offload time, but I will mention that ambulance patient offload time APOT teams were developed, actually 24 teams, and they were deployed to provide support for hospitals to reduce wall time. And that was received very well, a lot of great positive comments on the APOT teams. However, it was noted that APOT teams did not fully understand their roles, which caused some confusion early on in the deployment. And again, I think this kind of got better as times went on. Also, for state-level medical staffing, obviously the California Medical Assistant Team, CalMAT program, was had a huge impact on state for caring for alternate care sites, skilled nursing facilities, medical clinics, vaccination sites, and so on. But pre-COVID, we only had about 180 members, and we just grew that program from 180 members to nearly 2,000 during the peak of the response. We're now down around 1,200. But with that came some challenges. We had challenges around training. We had some challenges around having the appropriate policies and procedures. We had, CalMAT members that this was their first time being deployed. I mean, bringing on that number, in a short period of time. So it created some challenges for us. But again, as we went through this long response, we worked through many of those challenges. One thing I will say, though, that stood out was site leadership at the many medical missions that we were supporting. And throughout this response, we supported about 143 different medical missions. But site leadership was a challenge primarily because the EMS authority, particularly in disaster medical services, we really did not have the staffing available, so we had to rely on our California Medical Assistant Team's emergency hires, which also created some challenges. So some improvement items that we're looking at is continue to improve the EMSA response capabilities with our CalMAT program. We have established a work group, and we are looking at how we can really capitalize on all the lessons learned and move the program forward because it is quite viable for California. We're also going to provide more transparency and guidance around the use of paid contract medical staff and on the allocation of paid contract medical staff. And another improvement item is to work to make the APOT team concept a permanent solution to long ER bid delays and busy 911 systems. One way is to create a mission description to provide APOT teams outlining mission parameters, including roles and responsibilities. Also, another improvement item is to include local DHV and MRC coordinators early when making significant changes to the DHV system. The next area is healthcare surge. Obviously, the hospital surge build-outs proved very successful. We ended up building out 35 different hospitals, 18 skilled nursing facilities, which amounted to nearly 1,500 beds for California. That was a huge success. The decision to build out hospitals and move away from alternate care sites also proved to be the more effective approach. I will say, talking about ACSs, that the state-run alternate care sites were a good tool in certain circumstances, but were underutilized at some sites due to limited admission criteria and location. This was brought up at our after-action meetings. Particularly the ACS in Imperial was highly effective, really helped to decompress the hospitals there. But other locations such as Porterville and Sleep Train in Sacramento, there were some concerns around the admission criteria and the location. Another healthcare surge item was the approved LIMSA optional scope of practice for paramedics was viewed as a best practice and should be memorialized for future use in healthcare surge. And some of the practices or best practices included providing care in non-EMS settings during the worst COVID surges, to support alternate care sites, skilled nursing facilities, and other healthcare facilities, allowing EMTs and paramedics to administer COVID vaccinations, and allow paramedics to staff APOT teams in hospitals, ERs to decompress backlogs in the 911 system. And some improvement plan items include local representatives early in the decision-making process when deciding which facilities to build out state-supported medical surgery. And I will say that we did do that. There was a lot of collaboration going on, though this was still brought up, and it's something that we'll, look at. Also, place alternate care sites strategically in collaboration with local jurisdictions. And again, I think at the state level, we worked hard to do that, but we do recognize the concern. Another item is to add the LIMSA optional scope of practice into future pandemic planning as best practice and reinitiate state level or state-led crisis. And I can tell you that for the EMS Authority, we did a lot of work to bolster our capabilities to be able to provide statewide support. I mean, we went from a 30,000 square foot warehouse to a 250,000 square foot multiple warehouses in order to meet the statewide needs. But we did struggle because there were some staffing shortages, we had some training deficiencies, and we needed a better inventory management tool. Again, we found workarounds and we were able to be effective throughout this response, but these are some areas that we are continuing to look at. Also, in regards to medical equipment and supplies, the supply chain issues created competition and scarce resources at all response levels. And we know that the establishment of the state multi-agency coordination group to adjudicate scarce resources and prioritize fulfillment helped with supporting medical supply needs. However, it was noted that communications out of the MAC group were sometimes lacking, and the process for distributing resources was not always clearly understood. We did stand up the MAC group at the state level on multiple occasions, and I think the communication at times lacked a bit. This is something that we understand, and of course, moving forward, we'll continue to improve. Another point I will mention is implementing the statewide Salesforce system for resource requesting created some communication shortfalls, although we know that Salesforce proved to be a very effective tool statewide and something we'll look at using going forward. But despite the disconnect, Salesforce did help to streamline the resource requesting process and created much needed statewide standardization. The primary problem, though, was that many local jurisdictions did not use Salesforce, and then when they needed to switch to Salesforce, they had to forgo the system that they knew. However, we do know that it was very successful. The improvement plan items include developing a process for improved interagency communication and coordination regarding scarce resource allocation and implementing medical logistics inventory management system, encompassing our department at EMSA as well as Department of Public Health and our partners at Cal OES, and we're in the process of trying to do that now. And to recruit permanent EMSA staff to support added state-level medical response capabilities. Again, this is something that we are addressing. Thankfully, we have received funding to improve staffing within EMSA and particularly disaster medical services, so we continue to move forward. And now the last point that I would mention is the overall state medical response system. And I will say the RDMHS, Regional Disaster Medical Health Specialist, and the Mohawk Programs Medical Health Operation Area Coordinator programs proved just critical. And extremely effective. And halfway through the response, adding a second RDMH for each of the 6 Cal OES mutual aid regions proved very beneficial to the RDMHS program. However, coordination of resources at the Mohawk level struggled to keep pace with some operational areas' identified needs. It was noted that the Mohawk program is inadequately staffed and needs funding to bolster program effectiveness. And we've heard this for years, and we've seen it over the past couple years. This is something that we understand at the EMS Authority, and we'll look to options, and we'll work collaboratively with our MedHealth partners. Some improvement plan items include provide more training and exercise opportunities to improve the standards in the Mohawk program statewide, obviously seek funding opportunities for the Mohawk program, and reestablish the California Public Health and Medical Emergency Operations Manual Work Group to provide plan updates based on lessons learned. So again, that's just a high-level overview for you. Obviously, I'd be here all day trying to cover all the areas. But in summary, I will say that the response over the last couple of years really taught us a lot. And from the conferences, the overall message or feedback was very, very positive. So I'll leave it at that and give opportunity for questions. Thank you.
Thank you, Chief Johnson. It's always impressive how much material and personnel the EMS Authority can move for these events. So very impressed by that. I have a first quick question. The 24 APOT teams, what were the personnel on those APOT teams?
We had two configurations. We had a team of 12 and a team of 18. The team of 12 had 6 nurses and 6 EMTs. And let me just make sure. And then we had a team of 18, which includes 6 nurses, 6 LVNs, and 6 EMTs.
Copy. So,
oh, not EMTs, but paramedics, sorry.
Copy. So no providers, no physicians?
No.
Which reflects our experience that was the most helpful intervention in our hospital, but of course just one hospital. Further discussion among commissioners? Commissioner Snyder.
Thank you for the thorough report. And just like Dr. Uner, I have questions on the APOT teams. Several hospitals in the LA County region received those APOT teams, and I had asked at the last meeting for Dr. Garzon to give me the price tag on those teams on what the state paid for all of them to be dispatched. In addition to that, because data seems to be lacking on this whole APOT area, I really wouldn't mind seeing, I don't know if anyone else is interested, the month before those were dispatched, the times during the dispatch, and the times after the dispatch for the designated facilities that received it. I think this is important data because everyone's saying how great it was and how it helped the APOT times. I don't see that reflected in several of the facilities in the LA County region. So maybe it's just because it's such an overpopulated area, but I really would like to see this data, and I haven't seen anything unless I missed an email on the price tag for those teams to be deployed that the state paid for. So thank you.
So this is Hernando Garzon, if I could respond to that. And I was going to give as a follow-up to Chief Johnson's report. So we actually had a third configuration for APOT teams. So the teams that included LVNs and nurses and even the paramedics initially were sent in to support emergency departments where the paramedics, what they did was decided upon by the hospital, but often they served as nurse extenders, starting IVs, giving medications within scope, helping transfer patients. So those teams largely supported the staffing in the emergency department, and in doing so, indirectly helped APOT teams. There was a third configuration that actually came later in our process, which was just to send either 4 or 6 medics or EMTs to serve specifically as wall medics, essentially, to not help with patient care in the emergency department, but essentially babysit and observe patients that were on the wall to be able to cut loose the transporting crews to return them back to service early. And usually the model used was that one paramedic or EMT can take care of 3 or up to 4 patients at once and cut off more. So the reports that we had was that the greatest benefit to wall times came from the teams of just EMT paramedics that were dedicated to serving on the wall and cutting loose transporting crews. So I think we would need to look at that data but independently and to verify those testimonials or those individual reports through data. In terms of the cost analysis that we did, I thought you were requesting for the paramedic team specifically, so I don't have teams for the 12 or 18 that included nurses and LVNs, but for the paramedic only, during the Omicron surge, the state paid an EMT rate of $100 an hour and a medic rate of $115 an hour. And then during non-Omicron, even before and after what we were paying when we were providing medics and EMTs were $80 an hour and medics were $100 an hour during the non-Omicron surge rates. And so you can translate that into 4 or 6 staff and how long they worked. I didn't have the weekly calculation, but that's the hourly what we paid for EMTs and medics.
That's fine, but how many were deployed total? I'm hearing X number of teams, so $100,000, $1 million. What did the state pay for this program to be implemented? What's the total number of folks deployed?
Okay, so
I'm curious. I don't know if anyone else is, but they're saying this is going to solve some of the ER holding and APOT problem. So what was the cost and what was the amount of people put out and what was the actual data that shows all this time-saving effort and deploying people back out? And I don't mean to be pushed back on here. I just think this is very important that we get the data right.
Absolutely. So apologies, we thought it was hourly rate. We can go back and calculate exactly how much all those teams cost. And then we do have all that data. We did a significant analysis and share some of this with the legislature, and we saw a huge decrease in ambulance patient offload time. So happy to just bundle that back up and share with the commission. Yeah.
Thank you.
Commissioner Gautreaux.
So I have a question on having paramedics watching patients in the hospital. With the increasing shortage of paramedics available for even staffing ambulances, is this sustainable? And how many times was an offered position not filled because simply there were no paramedics available to accept that?
So I think in terms of sustainability, we're not sure, right? I mean, I think candidly, we were pulling staff from other states. I don't think that's a secret by any means. I think in terms of the second question, Dr. Garzon, do you want to take that?
I'm sorry, what was the second question?
I guess the second question is if you were offering a position, okay, we need a paramedic to staff an emergency department for this period of time, what percentage of time were you successful in getting somebody to fill that? And was that stable over time, or did it become increasingly difficult to find those people?
So we had an adjudication process for all the requests that came in, for all it was personnel and supplies and things like that, because we had more requests than we had supplies. So we adjudicated that process and provided to the most impacted hospitals. I don't know the exact percentage of requests for these teams that we filled. I can look at that and we can get back to you on that.
But we never had a request come in that if it had been approved through the adjudication process, we were always able to fill that through contract staffing. We never had to decline a request due to not having available staff. We may have declined it due to other reasons, but not if a paramedic wasn't available.
Thank you. Commissioner Pierce?
And I would just like to follow up in terms of the sustainability question. I mean, first of all, I think the idea came to the state because we realized that local EMS agencies were using this as a potential solution locally, right? They were doing that. They had crafted the idea locally and were taking a medic in their own system and using that medic to care for 2 or 3 patients and cut loose transporting crews. So, but I think the other thing is acknowledging that this is really done in a crisis situation with a tremendous shortage. So in terms of sustainability, I think it's certainly a response to in a crisis setting when you're having very high wall times, insufficient ambulances on the road, those kinds of things. It's really not a daily operational practice.
Thank you. Commissioner Pierce?
Thank you. Mr. Johnson, thank you so much for your thorough report, as always. It's very informational. So this topic obviously is touching on the APOT, which is a problem that exists, whether it's in a crisis or during the Omicron surge. As we go into the fall season and we're seeing in the Southern Hemisphere the increase of influenza, is there any discussion at the EMSA level to institute these APOT teams in advance in a proactive approach so that we're not dealing with this in a crisis mode?
So in terms of implementing anything in advance, the governor's budget is I don't know if you saw the funding that was allocated, but that level of resources will not be available through this next winter surge.
Thank you.
Thank you. Further discussion among commissioners? Seeing none, any members of the public?
Ray Ramirez, Ontario Fire and Cal Chiefs. Just a question. My understanding is that some of these APOT responses were enabled due to the waivers the governor allowed that waived some of the practice setting limitations. So is having the paramedics work in the hospitals? My understanding that might be a regulatory or statutory change, but I didn't get a chance to take a deep dive into that. But just one of the things is the governor's emergency declarations and emergency orders allowed a lot of things to happen. And would that process still be available after those expire? That would be my question. Thanks.
So you're correct that the emergency orders allowed for paramedics to work in settings that they don't normally work in, including in the hospital setting here. I think there are a couple of comments. So without the emergency order in place, the paramedic can work for an ALS provider or a LEMSA and perhaps be tasked to a hospital, but it couldn't be, a paramedic couldn't be hired by the hospital because they couldn't work in the hospital space in that sense. But I think the other thing that this model showed, or the success of reducing the wall times, is that dedicating somebody to take care of those patients until full transfer of care can happen to the hospital. So if the hospital were to employ a healthcare staff member to fill that role, it would theoretically have as beneficial effect on the APOT. It doesn't necessarily have to be a medic, and doesn't have to be an EMS-driven solution necessarily. Just that with $80 or $100 an hour, or whatever the cost may be for that level of healthcare worker, that is a potential solution that hospitals can implement as well to address some of the APOT issues. Well, I mean, to work collaboratively, of course.
Thank you. Any further members of the public? Seeing none, thank you, Chief Johnson. Always very informative. And we'll move on to agenda item number 10, the items for the next agenda for the commissioners. I might start by saying that we were remiss in following through on putting paramedic vaccination and select viral testing, whether or not that can remain a local optional scope of practice, on the September agenda. That was requested by Drs. Bosson and Koenig, and my fault entirely. We did not put it on this agenda. We may table that to the next agenda. I think we should do that.
Received an email, Chairman and myself, and Zoe, I believe, as well, from Commissioner Ribeiro for items for the December and March commission meeting. The first would be to discuss the decreased pass rate for some programs post-COVID and what local training programs have done and what components seem to be repairing pass rates. So that's the first item for Commissioner Ribeiro. Second item is why some programs have far lower pass rates than others, and if there are a common set of issues involving low pass rate programs, the EMS Commission can learn about and discuss. And I think Zoe has this in the email that she can perhaps articulate better. Thank you.
Thank you, Vice Chair Burrows. Other members of the commission have any suggestions for the agenda items for next time?
I did want to actually talk about the opioid epidemic and to consider what data elements we have and what might be missing in KEMSIS today to be able to do a statewide analysis. I think what I'm interested in is, given the data that Dr. Koenig and everybody kind of knows how tragic it is, what % of those clients, patients, are actually being impacted by EMS? And what are our opportunities to expand that? And again, so just looking at what the existing data points are, hopefully being able to automate some type of a statewide report that would give us an idea of the incidence of Narcan being administered, the number of people successfully transported, the number dead on scene, and then comparing that to the medical examiner data and the other data that we have to find out whether EMS is really, what is the impact of the opioid epidemic actually on EMS? It would be, I don't think we can accomplish this in 3 months, but my point is that if we're going to collect data, let's use it. And this is one of the crises of the day, is opioid crisis. And so just thinking about what we might be able to start to assemble to look at how impactful we are and who are reaching and who are not reaching, frankly. Thanks.
Thank you, Commissioner Dunford. Any further members of the commission? Seeing none, we can move on to the next agenda item, which is public comment, an opportunity for public to comment on anything that has not been covered yet. None in the room. There goes Zoe has something.
Good afternoon. Zoe Jones, Executive Support Analyst for EMSA. I also received an email from Commissioner Barrow, who unfortunately could not attend today. So I will speak his email as public comment. He wanted to speak regarding the APOT recommendation discussion, and he wanted to bring up the point the APOT committee did good work, and most of the recommendations deserve action as soon as practical. He stated he has 3 issues he wanted to ask during the APOT recommendation part of this meeting. The first one is, one obvious issue is the first responders, LEMSAs, hospital key staff, and hospitals were represented on the committee, but the public and patients who have a major stake in addressing APOT issues was not adequately represented on the committee. That is one reason we need public review and comment on the recommendations before moving forward implementing or EMS Commission approval of these recommendations. The second issue is that there is some disagreement between the APOT data shared with the EMS Commission and hospital review and disparities regarding their view of the data. How do we investigate these data disparities so the data is vetted and any issues and solutions between the hospital data and reported through the EMSA APOT data can be addressed? And the third issue is, what is the process going forward regarding implementing the APOT recommendations? The working committee does not have the authority on its own to implement these recommendations they are making. I wanted to hear the process EMS Commission will go through to weigh in on, approved, or is this an internal EMSA process? Thank you.
Thank you.
So Zoe, you might have to repeat some of those to me. I'm not sure I captured that all at once. Maybe we'll start from the last one you just read and then go backwards. So in terms of internal process, you're absolutely right. And even IMSA doesn't have all the authority on all of these things. A lot of them require statute, budget, funding, regulatory opening. And so I think we plan to work collaboratively with all of our partners that we did with the APOT committee, as well as with the legislature and the Department of Finance and the administration to figure out how we're going to move that forward. And obviously the legislature doesn't come back into session until December. So a lot of TBD there. Sorry, can you read the second one again?
No problem at all. The second one was regarding disagreement between the APOT data that was shared with the EMS Commission and hospital review and disparities regarding their view of the data. The ask was, how do we investigate these data disparities so that the data is vetted and any issues and solutions between the hospital data and the data reported through the EMSA ambulance patient offload time data can be addressed?
Excellent. So I think, candidly, we're working with the Hospital Association and our hospital partners to understand any discrepancies. I think we feel a level of confidence in our KIMSIS data and our data dictionary and in our standards that we set for our EMS professionals and how they codify APOT time. So trying to understand exactly why those discrepancies exist. However, I will say, regardless of any minor discrepancies, the story of APOT still exists. And so I just want to continue to, we always want to move towards data transparency and integrity and get towards any discrepancies. However, I feel it's very important not to get wrapped around the axle around data here, knowing that the story statewide is that an APOT problem exists and we have to get to the solution. So obviously working on that as we can, but want to stay very solution focused. And I think, as another commissioner mentioned, not just spend our time pointing fingers. Yeah.
And just to add a little historical precedent to that and maybe inform that answer a little bit more, is that the definition for transfer of care and the times is in the, I believe it's a 2012 document that EMSA had put out that was built based on multi-stakeholder EMS and hospital input to define what is transfer of care, including the best practice recommendation that a signature by the RN at transfer of care be adopted. Move forward almost 10 years later. Some LEMSAs have done that to more degrees than others. I think that the APOT LEMSAs have done a lot of work between the LEMSA, the AL done as much work. So I think part of it too is going LEMSA by LEMSA to validate and verify recently. And so I think moving forward, the data continues to improve. One of the things that I think would be helpful is for us to have an assessment or validation of that so we know what the percentage is statewide that's reliable. And as Director Besnet said, I think that focusing on the solutions, because we know it's a problem, as we refine and improve the numbers.
And then just the other comment was addressing how there was a lack of representation for the public and patients in the APOT committee, and he suggested that public review and comment on the recommendations put forth by the committee before moving with implementation would be ideal.
I think that's something we're going to have to take back and look at how that might affect the actual recommendations themselves. Obviously, we want to ensure that advocates and we have a well-rounded understanding of the issue, but candidly, this was going on well before COVID-19, and it was just exacerbated by the pandemic. So I think that's something we're going to have to take back if we're going to open all these comments, all this voting package up to public comment.
Thank you so much. And since this wasn't really a member of the public, but rather a member of the commission, any further remarks from commissioners on this? Seeing none? And if nobody has anything else, we can move to adjourn the meeting.
Can we discuss the location of the meeting, just to remind everybody?
Please.
Well, is it in the Bay Area in December?
Oh, yes. December meeting, do we have a location yet? That came up yesterday and we weren't quite informed.
A huge thank you to Zoe, as always, who just does such a tremendous job to get us all together.
We're looking at doing it at the Holiday Inn Oakland Airport, which is close to the airport and 9 minutes away from where MDAC will be holding their meeting at Alameda EMS. I'm working to finalize the contract now, and we'll keep all of you updated as soon as it's secured.
Commissioner Reluccio.
Yeah, I just wanted to announce that in December, at the end of December, I am retiring. So I will be working with the California Conference of Local Health Officers for my replacement. And I will be at the next commission meeting, but that will be my last. And I just want to thank all of you for giving me the opportunity to serve on the commission on behalf of CCLHO.
Thank you, Commissioner Reluccio. And while we're thanking everybody, I want to thank Kent Gray and Zoe Jones and everybody else in the back row that made the meeting possible. Audiovisual, thank you so much. We know how easily this can go astray. So appreciate everybody. It's not only the commission chair could keep the agenda items straight, we have a perfect meeting. Thank you very much. We can adjourn the meeting.